Good evening, everybody. This is the Good Hormone Health webinar, How to Live to 100. I have everybody who is on the call muted, but we will have time for questions at each break. We'll go for about 20 minutes and then open it up for questions that you can do by doing the chat function. First question is, why should somebody want to live to 120? First of all, to enjoy a full life, not just years, but quality years, to be a productive member of society, to impart wisdom to your offsprings, and health providers and other patients are often selfless and don't take care of themselves. And I titled this, Why to Live to 100, in memory of John Wooden, who lived just barely less than 100. He died at the age of 99 in 2010, and I think he was a great hero. Why is it realistic to live to 100 in 2015? There's better screening, there's better treatment, there's more knowledge of diseases. And many issues I discuss are controversial. Discuss with your doctor. But I think a lot of these will be quite helpful to people. What can you do as a patient? First of all, be an informed consumer. The days of blindly following your doctor are long gone. Be your own advocate. Docs are overwhelmed and busy. You need to lobby and push for them to put you at their attention. And doctors in general like to get paid for their time, so you may need to pay for the doctor for their time and effort. Be organized, keep your own records, and get a good doctor that will listen to you and work with you. Try to make it as easy as possible for your doctor, and go to good doctors. If something seems illogical, get a second opinion. And in general, my approach that we'll hear about this evening is to identify and screen for major causes of disease. The major causes of disease include heart disease, strokes, cancer, and diabetes. Know when to screen, learn to do the right tests, improve modifiable risk factors. You can't pick your parents, but try to know your family history. Have a healthy lifestyle, take medications as needed, and there's a risk-benefit ratio for each person. I do not believe that each test has to be cost efficient for the population, but it has to be the risk-benefit has to be favorable for the individual patient. Many people procrastinate doing the testing and trying to change your lifestyle. Start now and set a time for everything to be done, for example, by your next birthday. Screening has risks. You identify an abnormality that may not be clinically important, may have a downside. Interventions have risks. Always think about the risk-benefit ratio. Medicines have side effects and interact. Only take what you need. Supplements have risk. Many of them are ineffective and or harmful. I think everybody would agree to eat healthy and exercise has very little side effects and is likely to be beneficial. What diseases can you prevent? I would say about 90% of diseases that people get that cause them to die are preventable. Some of the exceptions are some type of cancers, lymphomas. Sometimes you just get them, you can't prevent them. Some types of heart disease, such as congestive heart failure, types of heart valve problems, rare incidences of heart attacks, but most heart attacks can be preventable. Rare incidences of strokes, most strokes can be preventable. This table is a little bit complicated, but I really like it. This shows in 2005, the 10 leading causes of death in the United States. Heart disease is 26%, cancer is 23%, strokes 6%, respiratory diseases 5.3%, unintentional injury about 5%, diabetes is 3%, Alzheimer's disease is about 3%, influenza and pneumonia about 2.5%, kidney problems 1.8%, sepsis 1.4%, and other diseases about 23%. So we're going to start by talking about heart disease. Heart disease is also called atherosclerosis or coronary artery disease. In heart disease, you get a cholesterol plaques build up in the blood vessels of the heart, supplying blood to the heart muscle. These plaques become calcified. As the plaques get larger, not enough blood goes through the arteries to the heart, and you get what's called angina. Angina is chest pain or chest pressure. It's due to not enough blood going to the heart muscle. Angina almost always starts at exertion, as the heart needs more blood to keep up with the increased demand on the heart when you exercise or walk. So usually if something's happening at rest, it's almost never angina. We'll show this picture again, but here's an example of a plaque right here and a plaque right here. There's different arteries, and the plaques are getting bigger and bigger, and eventually it will cause the artery not to have proper blood flow, and you would get initially angina. As the plaques increase in size, the angina gets worse, and it may eventually start occurring at rest. If the artery is blocked, you get a heart attack. A heart attack is also called a myocardial infarction, or MI. It's usually cresting chest pain, but it can be atypical. It can be shoulder pain, on the left side running down the arm. And women especially have more atypical types of chest pain as part of the heart attack than men do. It leads to damage of the heart muscles, and the heart eventually stops working well, and you get heart failure. It's also associated with arrhythmias, so you don't want to get a heart attack and its subsequent damage. If you are having a heart attack, call 911 and take an aspirin. In the emergency room, they can dissolve the clot or open up the clot with angioplasty, and the damage can be quite minimal if you can get to the hospital right away. There are different tests to evaluate heart disease. I'm not a cardiologist, but I do want to share my thoughts on these. Common test is done is called an EKG, electrocardiogram. It can detect angina, which again is impaired blood flow to the muscles. It can show a current or prior heart attack. It can show arrhythmias, but it cannot detect early blockage of your heart vessels. Another test commonly used is called a stress test. This can detect angina on exertion or major blockage of the heart vessels. Echocardiogram can detect heart failure, structural problems, and prior damage to the heart. Angiography can detect various degrees of blockage in the heart, but is quite invasive. There are these type of high-resolution CAT scans and MRIs that are new, somewhat experimental, but they are likely to have a role. The test I recommend is called electron beam CAT scan of the heart, or EBCT. I call it priceless. This is often part of what is called a body scan, which also looks for lung cancer and other types of cancer. The electron beam CAT scan of the heart detects early calcification in the heart vessels. Radiation exposure is low. Early calcification is a sign of atherosclerosis. The electron beam CAT scan of the heart is done at most major medical centers and costs between $160 and $500 and may or may not be covered with insurance. When you get an electron beam CAT scan of the heart, you get a calcium score, which indicates how much calcium plaques the patient has in their heart vessels. It tells you the number of plaques and how big it is, and that gives you a calcium score. It usually tells you which coronary arteries contain the plaques. And it also tells you often the number of plaques in the aorta, in the aorta, which is often less important than the plaques in the actual heart vessels. In some circumstances, the calcium plaques are in a dangerous region, such as in the main coronary artery called the left anterior descending artery, and it may be more dangerous having them there than in a more minor heart vessel. The person can get a 0 score, which is ideal. The lower the score, the better. And as you age, usually your score goes up. Generally, a score of 300 is considered dangerous. Who should get an electron beam CAT scan of the heart? Men who are greater than 40 years, women who are greater than 45 years. Patients that are being considered for treatment of elevated cholesterol. So I rarely put somebody on a statin drug without doing this test, because cholesterol is only a marker for heart disease. It's much better to look for the actual heart disease. If you have no calcifications in your heart vessels, it really doesn't matter what your cholesterol is, as you're not going to die from or develop atherosclerosis. However, a low percentage of people have what's called light fluffy LDL particles that don't give calcifications but can lead to heart disease. But the majority of the time, there's an excellent correlation between the amount of calcification and whether you develop atherosclerosis. If you do not have significant coronary calcification, if you have significant coronary calcification and your calcium score is pretty high, you should be on a drug designed to lower your cholesterol, such as a statin drug. You should take an aspirin. You could be on other dietary and exercise modifications to really decrease your chance of having heart disease, and you probably should see a cardiologist. So the two caveats are a few people that can have a negative calcium score and have these light fluffy particles, and some people can have a good cholesterol profile and still get heart disease. So neither test is perfect. Here's a sample result here. This patient had one plaque that was quite small in their left anterior descending artery, gave a low calcium score. In the cervical complex, one of the smaller arteries, there was a plaque that was bigger, so the score was 23.8. In the aorta, there was a lot of plaque. There's a big plaque, but as I said, the aorta is less important. So in terms of the coronaries, the person's had 2 plaques and had a calcium score of 24, which is pretty reasonable. So here's what happens on this picture here. You can see there's one plaque over here in the left anterior descending, and another plaque that's slightly bigger in the circumflex artery. And as the MasterCard commercial says, price of the EBCT, $150 to $500, knowing that you have clean coronary arteries, priceless. So what kind of medical treatment should you take to prevent or treat heart disease? The classic one is aspirin. A baby aspirin has 81 milligrams a day, a regular aspirin 325 milligrams a day. And it used to be said that taking an aspirin was the most important thing you could do to prevent coronary artery disease. However, the evidence is shifting and aspirin is less strongly recommended. Aspirin leads to gastrointestinal bleeding and maybe some type of cerebral vascular or stroke type of hemorrhages. Studies have shown that aspirin is effective in men in preventing heart disease, but the question is the risk-benefit ratio favorable, the benefit-risk ratio favorable, and in women it's in preventing strokes. Aspirin is likely to be more beneficial in those patients that have risk factors for heart disease, such as an elevated cholesterol, high blood pressure, and diabetes. Of note, the most beneficial study at reducing heart attacks was called the Physician's Health Study, which studied men and gave an aspirin a dose of 325 milligrams every other day. Other studies using smaller doses were less effective. The United States Prevention Service Task Force recommends, recommendations include encourage, it doesn't say requires, but encourage men aged 45 to 79 to use aspirin when the potential benefits of reduction in heart attacks outweighs the potential harm and the risk of gastrointestinal bleeding. Encourage women ages 55 to 79 to use an aspirin when the potential benefit of reduction in ischemic strokes outweighs the potential harm in the increase in GI hemorrhage. Do not encourage aspirin use for cardiovascular disease prevention in women younger than 55 and in men younger than 45. And the evidence is insufficient to assess the benefits and harms of aspirin for cardiovascular disease in men and women grades 80 or older. My recommendations for aspirin include anybody with a positive score on their heart scan, which is why I think the heart scan is so important. Anybody with a history of heart disease, men greater than 45 with an elevated cholesterol or diabetes, men greater than 45 or women greater than 55 with high blood pressure. And I would use what they did in that male health study, male health physician study, take either, which is 162 milligrams per day. So that would either be 2 baby aspirins a day or 1 325 milligram full aspirin every other day. The other thing to prevent or treat heart disease is blood pressure control. Target blood pressure should be about 140 over 80. Both too high blood pressure and too low blood pressure can both be harmful. The first thing is to use diet, exercise, and be on a low-salt diet. And the caveat is, I think our recommendations against low salt is shifting. Low salt only lowers blood pressure in a small percentage of hypertension, and evidence is shifting against recommending low salt. For example, there's a great Scientific American article in July 2011 about the myths of low-salt diets, and I encourage people to look at that. It actually turns out that sugar is more important to high blood pressure than salt is. So this seems to be a new finding, but I would really concentrate more on the sugar than the salt and try to avoid your stress. Make sure your if you have a blood pressure monitor, it's accurate, and you don't have white coat syndrome. So some people have high blood pressure just when they see the doctor. It's important to check at home when you're not with the doctor. Most drugs works pretty well, and sometimes they have to be in combinations. The best drugs include diuretics. The common one is hydrochlorothiazide, that is cheap and effective, but it does raise cholesterol slightly. Drugs called ACE inhibitors like benazepril and lisinopril, and angiotensin receptor blockers like Cosar and Diovan are also good choices. Brings us to cholesterol-lowering agents, and in terms of the cholesterol, most people know this. LDL cholesterol is the bad cholesterol. High levels are strongly linked to heart disease. HDL cholesterol is good cholesterol. Low levels are linked to heart disease. Triglycerides are the fat in the blood. Very high levels are related to pancreatitis, and there's a slight but not that substantial relation to heart disease. There's something called a non-HDL cholesterol, which is worth looking at. Takes your total cholesterol minus your HDL, and that somewhat incorporates the effects of triglycerides and also sort of incorporates the effects of the total cholesterol and the HDL, and that's also linked to heart disease. You have things called apolipoproteins. These are proteins that bind to cholesterol-related heart disease. In general, measuring these do not add that much to your management of heart disease. You can measure what's called a C-reactive protein, or CRP. It's a marker of inflammation and is linked to heart disease, and will tell you whether you have a lot of inflammation that could lead to heart disease. The drugs that are used to treat high cholesterol are statins. They block cholesterol synthesis. The most common ones are Lipitor, Zocor, which is also generic, made as simvastatin. It's very inexpensive. Crestor. Prevacol is a good drug that is metabolized differently in the liver than the other ones. Some people that have side effects from the other ones can try Prevacol. It's also called Pravastatin. And basically any drug that works is okay. They all work to lower your cholesterol. The ones like Crestor and Lipitor are usually a little bit more effective. They reduce inflammation and lower your C-reactive protein. They are the most widely prescribed class of medicines currently in the United States. They are heavily pushed by industry, but they definitely reduce heart disease and death. The side effects are numerous and maybe a little bit underemphasized, and they include muscle pain, memory problems, which is a crucial one, cramps, and elevated liver tests. And if you get these side effects, it's worth probably stopping in and trying a different statin. Who should get a statin? Anybody with plaques on EBCT, which is again why I think the EBCT is so crucial. Somebody with an LDL cholesterol greater than 160. If you have another risk factor, you're greater than 50, family history of heart disease, or a smoker, your LDL greater than 130. If you have diabetes, kidney disease, or your LDL is greater, if you have diabetes or kidney disease, if your LDL is greater than 100, you should go on a statin. And if you have a history of an MI or known heart disease, your LDL is greater than 70, you should go on a statin. We'll talk about fish oils. Fish oils are based on the idea that you have linoleic acid, which is omega-6 fat, and linolenic acid, which is omega-3 fat. The ratio is important. Too much omega-6 fat leads to inflammation and damage to the organ. Omega-6 is in fried foods, snacks, and other foods with corn oil. Omega-3 fat is in fish, especially ocean-caught fish, and not farmed fish. Ocean fish can be expensive, though. Walnuts, fruits, and vegetables all have omega-3s in it. You can supplement omega-3s. However, it's probably better to get them from the fish. Omega-3 fat-fortified ice cream and margarine have a lot of calories and fat. I usually don't recommend it. It's best to eat foods that are high in omega-3 fats. Okay, we're going to open it up to questions now. Let me go to the chat thing, and we have a couple of questions already, and we'll open it up to. So the first question is from Adina. Can hormone therapy, and then again, anyone can use the chat button to give us questions, give me questions. Can hormone replacement therapy help us lift 100 with the energy and body strength quality of a young person? It can help, certainly. Can many neurogenic, let's see that question again. So proper hormone replacement is crucial. And if somebody has pituitary problems, thyroid problems, adrenal problems, usually would be replaced. and that will certainly help you live a quality life and have energy and strength. What about stem cell rejuvenation for the pituitary? What about PRP? Adina, what's PRP? Chat me back. Stem cell rejuvenation is really not ready for prime time yet. There has been a lot of work with stem cells for heart disease in general. It hasn't been that effective. I think the heart disease will probably be the first one. There is some talk and some projects about trying to replace the pituitary. I worked with one of my surgery colleagues on trying to get a study going, and we never really started on replacing the pituitary with potential stem cells. Adina also asked, can a person with hypopituitarism live to 100? We know there are many neurogenic hormones and others that we don't know enough and cannot replace. There are plenty of hormones that we don't replace, but I think replacing them is probably a key. In general, patients with hypopituitarism don't live to 100. They have a short mortality. It used to be thought that was due to lack of growth hormone deficiency. Now, most patients with hypopituitarism are replacing growth hormone deficiency, and I don't think there's been studies more recently to show that increases the lifespan. Most patients, most women do not get replaced with testosterone. Certainly my patients do. And most patients don't get replaced with oxytocin. We're starting to replace that in some patients. So it's unclear whether or not that's going to make a difference in the long term. Adina also asked, I'm on a baby aspirin. My cardiologist put it on me because of my stroke, blood pressure, fluctuations, aortic valve regurgitation, mitral valve prolapse, high CRP and other inflammatory markers. Because of arthritis being bad and centralized pain, is the baby aspirin a bad idea? I don't think so. I think it's a good idea. I think this person should get a EBCT to really look at how bad their heart vessels are. But from what it's saying, I think it would be a reasonable therapy. And Adina talks about platelet-rich plasma therapy. I really don't have enough experience in that to make a case for her against in patients with pituitary problems in general for hormone replacement. Any other chat questions? And Adina, did I somewhat answer your questions? Okay, thanks, Adina. Okay, we're going to go on to cancers. So there are several genetic and environmental causes of cancers. Try to avoid toxic chemicals. For example, in our neighborhood in Los Angeles, there is an oil refinery, and I would say in our neighborhood we have a higher rate of cancers. So I'm not going to move, but be wary of that. And I think New Jersey is known for a lot of oil refineries and carcinogens, and I would be cautious about that. Solvents and other chemicals, I think the question is why are cancer rates increasing? It probably has to do with some of these chemicals we're exposed to. Clearly, obesity and poor diet are related to cancers. Do not smoke, and the cancers can affect both men and women. The cancers in men include colon cancer, prostate cancer, and lung cancer. In women, breast cancer, colon cancer, ovarian cancer, uterine and cervical cancer, and lung cancer. Other cancers include brain cancers, lymphomas, leukemias, pancreas cancer, kidney cancer, and stomach cancer. So one of the most common ones that's very treatable is colon cancer, and the best test is a colonoscopy, where usually a GI doctor looks in your colon and looks for if there's any polyps or cancers. Most colon cancer starts as polyps, and if you do a colonoscopy and you find polyps, they can be gotten rid of, and they'll prevent them from getting cancer. The prep is not that pleasant, but otherwise it's easy, and I would recommend this. I usually recommend a little earlier than most societies do. I think for males at the age of 40, females at the age of 45 would be reasonable. If it's negative, you should get another one every 5 to 10 years. Any male with anemia should get a colonoscopy, especially if they're over 40. Most females have anemia because of their menses, so you don't need a colonoscopy if you have anemia unless you're postmenopausal. There are other tests such as a sigmoidoscopy or stool or cold blood that some healthcare organizations advocate as being more cost effective. I think if you're going to get the test done, do the best test, which is a colonoscopy. And I don't recommend virtual colonoscopies now. I don't think they're quite as good as real colonoscopies, but I think they're getting better, and they may in the future be just as good. For lung cancer, don't smoke. If you do smoke, you should get a body scan that includes a high-resolution CT scan of the neck. I would probably start that somewhere in your 40s and maybe every 5 years. There's been a couple studies showing that these high-resolution CT scans are cost-effective and do pick up cancers. It's probably worth it a male to get one at the age of 50 and a woman at the age of 55, at least one of it. The problem is that they can pick up other lesions that require a biopsy that may not be cancer, but I still think it's probably worth it to get one, and you at least have a baseline, and then you can see if it's growing or not. Prostate cancer is a very interesting and I think informative cancer to look at. It shows sometimes the testing is really not that beneficial, but I would still recommend it for the most part. The key test is called a prostate-specific antigen, or PSA. It's recommended to get it every 5 years starting at the age of 50. You can get a digital rectal exam. I'm not sure these are really that helpful. If either are suspicious, if your doctor finds something on a rectal exam or your PSA starts going up, you can get an ultrasound or MRI. The problem is many men have slow-growing prostate cancer that doesn't affect their life, and it's better if it's not known. Right now, there's no test to tell between the slow-growing and aggressive cancers. This will change in the future. The intervention may be worse than the disease. The interventions such as the surgery, radiation include erectile dysfunction and decrease of testosterone, which leads to osteoporosis. And the rate of increase of PSA may be more accurate than the actual level. However, I would still recommend getting it. I think you should get it, as I said in the first sentence, men should get it every 5 years starting at the age of 50. Breast cancer is obviously an extremely devastating disease. It is picked up primarily by mammogram. I would recommend starting at the age of 40. Many societies are delaying the age. I don't think that's a good idea. Problem is it can pick up benign lesions that lead to unnecessary surgery. Ultrasounds and MRIs are probably not done as much. They should complement a mammogram, and they can often tell whether something is more benign or more malignant and needs to be biopsied. And if you have a strong family history or suspicious lesions, an ultrasound or MRI is very important. BRCA, BRCA screening, I'd recommend if there's a strong family history of early breast or ovarian cancers, and it's very common in Ashkenazi Jews. There are many genetic markers coming, but right now the mammogram is still the key test. Self-exam doesn't really hurt, but I don't think it substitutes for a good mammogram. Now, this is something that I just heard in a lecture. I think this is extremely important that most doctors don't know about. There's a new test for ovarian cancer. It came out about 3 years ago, and it is commercially available at Quest. So it's really ready for people to actually do the test, not just experimental. It's called a multivariate index assay. It's also called OVA1 or IVD-MIA. It's a blood test that picks up ovarian cancer. I think it would be reasonable to get it every 3 years starting at the age of 40. Combines results from 5 tests, the CA125, prealbumin, apolipoprotein, beta-2 microglobulin, and transferrin. And some of these go up in cancer, some go down, and it gives you a score between 0 and 10. A higher value corresponds to a high rate of malignancy. It's done in patients with malignancy. It should be done in parallel with a pelvic ultrasound. If you have a pelvic ultrasound that shows something suspicious in the ovaries, you should do this test. And if you do this test that shows something suspicious, you should do the pelvic ultrasound. The old test that was recommended by itself, the CA125, is not really as good as its panel testing, and I wouldn't recommend it alone. Again, if you have family history of early breast cancer or ovarian cancer, it's good to get a BRCA, and if you should get a pelvic exam starting at the age of 40. For cervical cancer, there is a fairly new virus called the human papilloma virus that is given as for teenagers. I would recommend that all teenagers get it. It's less effective if you get it as an adult. You can talk to your doctor about whether it's worth it or not. if you haven't had it as a child, as a teenager, and you should also get liquid-based pap smears. In general, cervical cancer is being recognized as being part of a papilloma virus. Endometrial cancer occurs in postmenopausal women that have vaginal bleeding. So if you have postmenopausal bleeding, go see your gynecologist and get an ultrasound and probably a biopsy. Other cancers, I would recommend getting a CBC, which is your blood count to look for leukemia starting at age 50 every year. New onset depression should be a possible flag for cancers, brain, pancreas, and colon cancer. Unexpected weight gain is also a flag for cancers. For cancer prevention, I recommend a good diet, exercise. The drug used to treat prediabetes or diabetes, metformin, has definitely been shown to decrease rates of cancer, especially people that are overweight. I think if somebody is overweight, we talked about being overweight leading to cancers, metformin will help nullify that effect, and it will be a reasonable drug to take for cancer prevention. Strokes, the same risk factors and markers as heart disease. Try to have good blood pressure control, 140/80. Do that EBCT. It shows calcifications in the aorta, which is similar to the carotid neck arteries. You could also do a carotid ultrasound. It shows the media thickness and plaques in neck arteries. I would say do that every 5 years starting at the age of 45, especially if you have high blood pressure. If you have high blood pressure, high cholesterol, take that aspirin, as we discussed before. It should help prevent strokes as well. Okay, let's open it up to some more questions. Okay, so first of all, Adina asked, how to be cautious, especially if you live in New Jersey? I would say that if you do live in a carcinogenic area, probably do more screening than otherwise. You know, do make sure you get those mammograms, start your colonoscopies. Just be a little bit more alert than other people. If you have a lot of people in your neighborhood dying at a young age of cancers, maybe consider moving. Elizabeth asked, should you take an aspirin if you have a normal EBCT but a high risk of a stroke due to family history? I would probably get, in that case, the carotid ultrasound. If your carotid ultrasound is okay, I think you probably don't need to do it. You know, the family history and sort of the family history is probably dependent on things like high blood pressure and cholesterol. If you don't have that high of cholesterol and you don't have high blood pressure, you just have a family history, I would do the carotid ultrasound. If that's okay and your EBCT is okay, I think you can pass on the aspirin. Adina said that she had a polyp at M27. It's so horrible. I'm waiting for science to make a better experience before I have another one in terms of the colonoscopy. You know, I would probably wait 5 years. I don't think I would wait that long. In general, the polyps are slow growing. If you could do one every 5 years, you'll probably catch it before it becomes a cancer. Janet asked about, she says she's healthy at 66, had hypopituitarism at age 18, her calcium score is equal to an 18-year-old. Should she be taking an aspirin daily? I would say no. She has EBCT score pretty low and doesn't have any risk factors for strokes. I think she should probably pass on the cancer. Young people that have hypopituitarism, health-wise, are they more elderly? I would say probably not. In general, there is some data about growth hormone, IGF-1s, being linked to cancers, but I just saw a recent article that, and you know, it's thought that higher IGF-1s lead to cancers, but there was a recent article showing that lower IGF-1s can lead to cancer. So we used to think that people with hypopituitarism were protected from cancers because their IGF-1 was low, but I'm not so sure about that. In general, patients with hypopituitarism do have higher mortality, but I think some of that is improper replacement. Some of them are over-replaced on cortisol, which can lead to, you know, obesity, prediabetes, and all that may lead to more diseases than otherwise. But I think, people should be on proper replacement. Adina asked about mammogram, wait till I'm 40. My grandmother had breast cancer, but as she smoked, I think she can wait till 40. She asked about the over 1 test. I think that would be reasonable to get, considering the, well, I don't know, maybe at the age of 40 she should get it. She didn't sound like Adina has a family history of ovarian cancer. Is thermography effective for breast imaging? They seem to see lesions earlier. I think thermography is an excellent choice also, and it should probably be done complementary to a mammogram. I think that's a great suggestion, Elizabeth. Adina asked about postmenopausal bleeding. You don't really have postmenopausal bleeding. You're on estrogen replacement at premature age, and we're trying to reduce your period. What I'm talking about is somebody that's really postmenopausal and is on either nothing and get estrogen replacement, or somebody is on estrogen plus continuous progesterone where they should not get bleeding and they get bleeding. So if Adina could email me afterwards what type of regimen she's on with her estrogen and progesterone, I'll answer that by email. Does taking hormone replacements affect immune function? And is there an increased risk of cancer for hypopituitary patients? So patients that have hypopituitarism in general have some immune dysfunction. Addison's patients have immune dysfunction. I think most patients are, if they're not on replacement, their immune system is poor. If they're on proper replacement, I think their immune system should be reasonably good. And from what I understand, I think there is a slight increased risk of cancer for patients with hypopituitarism, but it might be because they're overtreated on cortisol and they're overweight and not necessarily on the replacement. I think some people aren't on proper replacement. Neil asked that he was diagnosed with diverticulitis last week after a stay in the hospital for 4 days. He was instructed to continue antibiotics at home. Should I insist on a colonoscopy? I would say a colonoscopy would probably be reasonable in this case. The diverticulitis could be diverticulosis also, which is like a pocket of bowel that can harbor things like nuts and stuff like that. And I think that would be a reasonable choice for Neil to get a colonoscopy. Janet asked if radiation causes cancer. I'm concerned about mammograms. Are you? I think you have to weigh the pros and cons. I think picking up breast cancer with a mammogram is extremely beneficial. There is a little bit of risk, but I would say for most people, the benefit outweighs the risk. Kelly asked, what I was thinking about is the timing amount and timing of pro-inflammatory cytokines are important. With losing the timing and response to hormones, does it impact the immune system response that would take care of the potential cancers? I think that's a great question there. So in general, being overweight, you have more pro-inflammatory cytokines, which can lead to getting cancers. Many patients with hypopituitarism, either because they're not properly replaced, they're over-replaced on cortisol, not properly replaced on growth hormone, not properly replaced on testosterone, maybe not properly replaced on oxytocin, are overweight, and therefore they have too much pro-inflammatory cytokines and not enough anti-inflammatory cytokines, and this may affect the response to cancers. Again, in general, the higher the IGF-1 is a growth factor, can lead to cancer formation. People used to think that patients with hypopituitarism, because they had low IGF-1, may have some type of protection. But as long as your IGF-1 is properly replaced, you're not over-replaced, I think your chances are reasonably good that you will do okay in terms of that. Elizabeth asked about CD57 as a measure of immune function. I'm not sure about that. I'm not exactly an expert on that, but I think the best measure of immune function is really your how much symptoms you get. There are T cell markers and B cell markers, and some of those may be helpful, although I'm not that much of an expert on that. Adina asked about postmenopausal or not. I would say no. I would say she has hypopituitarism. She's not postmenopausal. She also says taking too much cortisol leads to high inflammation. Correct. So too much cortisol leads to being overweight, and that can give you inflammation. Too little cortisol, on the other hand, can also give you inflammation. And cortisol can treat inflammation. Cortisol is anti-inflammatory. So I would say cortisol per se doesn't lead to high inflammation, but some of the chronic effects of weight gain. Janet says, I've had many reports of people who have had devastating side effects from the HPV vaccine. I would tend to avoid it, but you think it's a good thing. I went to a lecture of one of my colleagues who's an OBGYN, and the data is extremely favorable. There's extremely low risks of side effects from HPV. I would say that would be one that the benefits outweigh the risks by far. Adina then asked how there would be postmenopausal to 100. I would say that's not true. I think, you know, we sort of changed the terminology to when somebody reaches menopausal age, even if they have hypopituitarism, we start calling them postmenopausal. So let's do, we'll talk about diabetes and maybe one more topic, and then we'll call it an evening and pick it up next week. Diabetes is very linked to being overweight and inactive. Your fasting glucose should be less than 100. If it's above that, it's called impaired fasting glucose. It's reasonable to get that screened yearly. Diabetes is a fasting glucose of greater than 126. Prediabetes is a fasting glucose between 101 and 125. The best way to prevent progression from prediabetes to diabetes is exercise and weight loss. I think it's very important to know you have prediabetes and to watch your progression. I did a study looking at can vitamin D prevent prediabetes to diabetes, which I'll talk about probably next week, and it was ineffective. So really the best way is exercise and weight loss. Fasting insulin, if it's greater than 15, is indicative of insulin resistance. Having a low SHBG, sex hormone binding globulin, is also a marker for insulin resistance. Prediabetes or insulin resistance patients can take the medicine metformin or glucophage and can increase their exercise. Hemoglobin A1C is becoming the test of choice, really. It measures average blood glucose levels, includes glucose after meals. It does not require fasting, so it's easy to do. Diabetes is defined as hemoglobin A1C greater than 6.5. Prediabetes is 5.7 to 6.4. I would recommend this getting tested yearly. Avoid getting diabetes. If you get it under control. Again, people that are on too much cortisol are predisposed to it. People that are growth hormone deficient can get diabetes. Growth hormone can also lead to diabetes, although I think that's less likely because you're feeling better when you're on your growth hormone and you really have less of a chance of getting diabetes. If you have diabetes, try to keep your hemoglobin A1C less than 6.5, your LDL cholesterol less than 100, your blood pressure less than 140 over 80. And we'll close off by talking about osteoporosis. Osteoporosis is thin bones, predisposes people to fractures, especially hip fractures. Hip fractures are a major cause of mortality. Bone density or DEXA scan in women starting at the age of 50 and men starting at the age of 65 would be a good recommendation. Mostly a disease of thin women. Patients obviously on glucocorticoids are more likely to get osteoporosis. To treat if you have osteoporosis, the main treatment is bisphosphonates like alendronate or called Fosamax. Try to follow. You should have follow-up if you have osteoporosis. If you have osteopenia, repeat your DEXA scans every few years. You could do measures of bone turnover. The test I recommend is called a urine entelopeptide. It's excellent in showing your bone turnover now. The DEXA scan shows it over cumulative effects. You should look for underlying cause. Vitamin D deficiency or high PTH can give you osteoporosis. They should be screened if you have it. Okay, let's go for the questions again. Kelly asked, how much of the protective benefit from exercise do we lose by not having the normal hormonal fluctuations that others have? I think that's a great question also. My guess is people that have hypopituitarism and hormonal fluctuations, they probably benefit more from exercise than the average person because, you know, they have their hormones being out of whack, they're getting a tendency to gain weight, and the exercise themselves would really help them. I'll show in a slide next week this idea that the ability to exercise is one of the best predictors of how long you live. And people that exercise and are able to exercise, they live longer, even if they're overweight, than somebody that's lean but can exercise and doesn't exercise. So I would say the hypopituitary patient and the thyroid patient, exercise is crucial. What is the best anti-diabetes diet, vegan or low carb? I would say they're both pretty similar. So I recommend basically a low carb diet with very little processed foods, sugar, high fructose corn syrup. Both of those diets are really the best. In terms of whether you should not eat we're going to talk about this next week, but in terms, I recommend people eating a moderate amount of protein like chicken and fish and turkey. If you chose not to do that, that's probably okay. Some vegans eat a lot of carbs, and I wouldn't recommend that. So I think the best thing, people call it a paleo diet with a lot of fruits and vegetables and some protein, almost no processed foods. Linda asked, I asked my endo if taking growth hormone will lower cortisol. She said no. It doesn't lower cortisol in your serum, but it does lower it in your cells. There's an enzyme called 11-beta-HSD1 that's regulated by growth hormone. When you take growth hormone, you break down cortisol in your cells, and that can lead to low intracellular cortisol, which can give you eventually even adrenal insufficiency. And you'll have the effect of lower cortisol by taking it. Linda says that this may be a borderline adrenal insufficient, and I would say that is correct, that if you are borderline adrenal insufficient and start taking growth hormone, it can make you truly adrenal insufficient. Dana says, great webinar, you should send it to the Surgeon General. I tried to get the Surgeon General to speak at my medical school for our Drug Addiction Research Day, and they wouldn't come. I don't know how much I have pulled with the Surgeon General. Should people take calcium, and should Dina? We'll talk about that next week. I have that as a specific slide for next week. Dina talks about the paleo diet. I think paleo diet is great for most people. Janet had a DEXA scan, PEP numbers decline, very conscious of diet and exercise, and takes vitamin D and vitamin K2. I think I should mention that vitamin K2 is an excellent way to treat your osteoporosis. Janet says her diet is excellent. I do not follow a paleo diet. That's high in protein because it depletes bones. What else can I do? I think it depends on how low the DEXA is. There's a big range in the osteopenic range, and most people don't go from osteopenia to osteoporosis. And most people with osteopenia don't have much problems with fractures. So it might not be anything to worry about. In general, people decline as they age, and cortisol certainly can give you increased osteoporosis. Janet's on proper cortisol replacements. I don't think that's likely, but I think it's just something to watch. I think she's doing basically all she can do. Linda asked, do you feel taking growth hormone may be beneficial to take? Maybe beneficial if you have to start taking a lower dose of cortisol. I think people should be on proper replacement. If they need growth hormone, they should be on it. And if it makes them catabolize cortisol more and being on a low dose of cortisol, I think they should probably be on it. I have to look at each case individually, and that's why hormone replacement is so tricky as they interact with each other. But I would say she probably should be on both. And to feel more balanced, socially active, and helping with weight, I think that would be a reasonable choice. Linda asks, I have 50% of my pituitary, and I'm only on DDAVP at the moment. She feels lucky, laugh out loud. People have different effects of having pituitary surgeries, and it depends on, what part of the pituitary is affected and what the hormones are. Linda says she feels yucky, so maybe she really needs to be on growth hormone or oxytocin or testosterone or thyroid medicine. She has to, we have to evaluate her for that. Linda says yes on oxytocin, yes on oxy, and she hopes to come see me. Great. Other questions? Linda's going to come from Western Canada. That'd be great. Love to see you. Okay, thanks, Dr. Friedman. Great. So I will send everybody another link. I'm not sure if the link is the same as it was this week for next week. We do plan to start at 6, and I think the second half should be very interesting. We did, pretty close to half now. Elizabeth asked about how old is it to take estrogen cream if you are hypopit. I usually recommend until about 60 or so. Over 60, I usually taper down. And Neil asked, is it possible that possible reason my testosterone crashed without changing the protocol? Anything you take can interact with things. You're not feeling so well. You're not eating as well. Some of that can affect levels to a small degree. I don't think it's enough to cause a crash. Okay, we'll see you guys next week. Janet asked about stopping estrogen replacement. Should I take testosterone? I'm not sure. I think the estrogen replacement would be crucial for her bones. We'll have to talk about that. And you could take testosterone without estrogen. I think that would be reasonable. And I think Janet, we decided because she's in her mid-60s, we should stop it. But we'll have to reassess that with her osteoporosis.